I'm sorry, today I think my internet is not doing that great, so that's why. Okay, so then when it comes to bipolar 2 disorder, there is hypomania episodes and no manic episode. Always think of there is no manic episode, but there is depression going on. People can present with like low mood, nothing want to do anything, don't want to do this, don't want to do that, like whatever they want, they're like, I don't want to do that, I don't feel like eating, I don't feel like sleeping, and it's start concerning. At that point becomes bipolar 2. Then the patients with the bipolar disorder are at a higher risk of suicide when they switch from mania to depression. So, especially as they become aware of consequences of their behavior during the manic episode. Because, like, if they spend too much after getting back to their senses, they start feeling bad. Lithium is among few agents with proven efficacy is at preventing suicide attempts and then completions. Then comes the treatment. What is the treatment? Treatment is basically lifestyle and then biological. Lifestyle is basically psychoeducation. It's very important. You have to tell the family, you have to tell the people who are living caregiver, educating all of them. Then at the same time, letting the patient know what he is going through. So always tell them the emergency plan for the manic episodes, promote the stable routine. Then the lithium is one of the most important. Lithium is the mood stabilizer. And for the bipolar is lithium, lamotrigine, duroxetine, and then Seroquel. So lithium anticonvulsants, antipsychotic, ECT is the one that we use. Mood stabilizer is very important. Don't go for something treating mania with the lithium, develop prox carbamazepine, preventing mania. And same as well with the lower doses. Treating depression with the lithium lurasidone. Then the mixed episodes or the rapid cycling. Then comes the psychological where you do the psychotherapy. This is important. What you need to do from here is basically knowing what are the CBT, IPT, interpersonal, social, vocational rehabilitation, and all of that. Anxiety is one of the thing. I mean, I'm not sure, like you guys can make a diagnosis of that one. So you have to think of what is a panic, what is panic disorder, and what is anxiety. Anxiety is basically fear of severity of threat or having restlessness, excessive thoughts, thinking about something for prolonged period of time. But when it comes to heart racing, your blood pressure rising, inability to sleep, breathing issues, then it comes to the panic disorder. Sorry, panic episode. Now, when you start having a fear of upcoming panic episode, then it becomes the panic disorder. I hope this kind of makes sense. This, you just need to build up your concept so you can make the diagnosis on the basis of what is going on. And it's very easy. If you make the concepts of our psychiatry, especially for the diagnosis, it's very easy because the questions are straightforward. They don't mix it. Okay. Psychiatric questions are one of the most easiest questions in the QE1 exam. Okay. So if you know, you know. If you don't know, then, you know, so in this one, mm, even I think I did not tell you about the when we were doing the depression. Sorry, I missed one thing here. The neurotransmitters of the depression. What are those ones? Okay, so just quickly read that one as we discuss the schizophrenia. So in this one, where is this one? Yeah, here. Which one is the neuroanatomy and then the neurophysiological? Which one is that one? The hippocampal volume, increase size of the ventricles, decrease REM latency, and then slow wave sleep and increase REM length. So in this one is in depression. Okay, so this is kind of important. That's why I'm coming back. Then you can think this one is all about the anxiety disorder where the heart, respiratory, endocrine could be all of them symptoms could be related to it one. Only proceed with a medical workup as clinically indicated. If you think that this person might have asthma, COPD, in those cases, we go for anxiety workup. Otherwise, usually people like 24-year-old, 18-year-old, if they present with restlessness and giving you, oh, I'm having a lot of stress these days. So one of the first thing that you would like to rule out is upcoming stress. In anxiety, in panic disorder, like upcoming exam fear or anything like that. This can give you an idea of anxiety. Okay. So they will always talk about stress, or in the question MCQs, they do like you to ask what would you assess. So any kind of new stressor. So current stress is important, childhood adversity or trauma. In the indigenous people, it's very important if you have to ask about their trauma. Okay. Then we already discussed about the panic disorder. Panic disorder is basically having a thought of upcoming panic attack. So palpitations, sweating, trembling, dizziness, presthesia, derealization, fear of loss, and everything. And it's followed by 1 month. In this one, the main important is CBT. People don't do CBT. They always wanted to start some treatment. So mainly we start with fluoxetine, sertraline. That's very common. Escitalopram, citalopram. These are the ones that we start with. And if it does not work, then switch on to other. Then when is the full response gonna come? 12 week. Then some people do ask for benzodiazepines. In that cases, we do give benzodiazepines only in the case when they have panic disorder, and only 1 or 2 tablets. That's it. Especially 1 milligram. They do ask for 5 milligram. I mean, in the old times, they do give 5 milligram, but now in the recent guidelines, we start giving the low doses. Panic attack and panic disorder. So, disorder is having a risk, recurrent, unexpected attack, and fear of another attack. Panic attack is basically, having the attack. Starting medication for anxiety, start low, go slow. Very important. Always think of aim high. People usually resolve with this one. Agoraphobia, this is mainly the diagnosis. You need to know what are those ones. It's basically the closed space, transportation, open spaces. In those ones, he has more like, where he has been going on with a lot of people home alone. So, and treat as it's like panic disorder. Then the generalized anxiety is basically this concentration, fatigue, irritability, restlessness, sleep disturbance, and tension. Always, always, always ask about coffee, alcohol, and sleep hygiene. Any kind of psychiatry, I would suggest. Social anxiety is basically when persistent for more than 6 months. This timeline is important, okay? Fear of the social and performance situation. Phobic is basically when you have some sort of agoraphobia, uh, claustrophobia, so some sort of where the phobias are going on. Then the environmental injection, situational, others. So quickly go through Google what are the common phobias and just read their names. Where the fear anxiety is there, okay? Is this one you have to educate the patient. CBT. We do give CBT for everyone, okay? Then comes the psychoeducation in some cases where you need to educate the patient about panic disorder, anxiety, depression, psychosis, mania. In those cases, you have to do the psychoeducation too. If you feel like this patient has judgment and insight. Then comes the OCD. I think we all pretty much know what is OCD. So basically, having urge for doing something, and compulsion is when you complete that urge. Here again, the neurological abnormalities is very important. Which one are not this one? Where is the Yeah, the brain injury could be there, and then Huntington chorea could be there, and then the Tourette syndrome. So this one, family history of OCD or Tourette syndrome. So sometimes they give you OCD history, or sometimes in the family they say one of the far off cousin or one of the father or mother, whatever, they have the Tourette syndrome. Now they can give you an idea about OCDs. CBT, same we do. Then psychotherapy starting with SSRI and SNRI. This is very common body dysmorphic. It's very common in the females and in especially the young females where they feel keep checking the mirror. So it's gonna be the question that's gonna be testing in NACOST. They usually give you kind of scenarios where you have to ask the questions, mirror checking, aggressive thoughts like anorexia nervosa. You have to always think of body dysmorphic thing too. So even in your MCQs, they can ask you what could be the differential diagnosis of anorexia nervosa or bulimia nervosa. In those ones, usually the body dysmorphic disorder is something that you have to keep that in your mind. And usually we go for CBD. And it's common in 15 years. So that's why they said rule out the eating disorder. Hoarding is when they're collecting things, keeping it for too long in their house. Trichotillomania, you have to know which one is trichotillomania. Which one is tinea capitis? Because in that case also there is a missing of hair. And if that is of dandruff or any kind of psoriasis going on in the scalp, so you have to see the pictures of that one. How does they look? So they can give you a case, a patient present with a hair loss at one place, and now that's how the scalp look like. So the picture they can show you and ask you what's the diagnosis. So you, and he has a recent stress going on. So stress can give you an idea that this is basically trichotillomania. And if this is basically an itchy scalp or redness and it's coming and going, and then you can see from the patch how does it look like. So you have to see the difference between all of three of them. Then skin picking is also one of the thing. Post-traumatic disorder, in this one is basically the if there is any previous trauma going on. So they can give you an idea about the trauma for sure. Okay, PTSD is there. So in this one, you have to always think about the sleep hygiene. Then the recurrent involuntary and intrusive dressing memories, then recurrent distressing memories, the dissociative reaction, intense or the prolonged psychotic disorders. So you can see the criteria from the sidebar. The traumatic event, re-experience the event, avoidance the stimuli associated with the trauma, unable to function more than a month, and arousal increase, plus negative alteration in the cognition and mood. And it's very common, especially in females. So in this one, CBT is one of the first line we go for, then early intervention CBT, then DBT, then we go start with the fluoxetine, prazosin for the sleep. Adjustment like move somewhere and now you are having the problem. Symptoms persist for 3 days to 1 month. So acute stress is basically 3 days to 1 month. After 1 month is basically PTSD. This one is also psychotherapy. Bereavement is grieving. In this one, there is staging of the grieving. First they cry, then they start accepting all of those ones. So you can read that one. After 12 months, if the patient continues to long for the deceased, experience intense sorrows, pain in the thing, so then it becomes a persistent complex bereavement disorder. This one you have to do the watchful waiting. Then comes the delirium. Delirium is something that can be presenting in the old people. It's very, very important because as a geriatric point of view. So delirium and dementia, we will do the difference. I think it's written somewhere in neurology or somewhere here. So we will see that one. The confusion assessment is basically CAM of the diagnosis of delirium. So an assessment intrusive that screens of overall cognitive mission. So acute area of fluctuating case, inattentiveness, thinking, altered level of consciousness. In those cases, we do this one. Then what are the clinical features? Common features are disturbance of attentiveness, distractibility, disorientation, sleep, wake, all this disturbance. So even if you are missing out something from this side, like, this chart, you can always read the sidebars and this is more than enough for you. Then comes the delirium, eye watch, death, so infection, urinary tract infection, then acute metabolic disorder, CNS pathology, trauma, hypoxia, deficiencies, endocrinopathies, acute vascular toxin. Then comes to the opioid is one of the most common that can cause this. In the assessment is basically observation, then clinical history, checking for CAM, confusion assessment method, then physical examination, then medical review. Checking for everything, CBC, electrolyte, vitamin B12, folate, as we discussed everything. Chest X-ray, CT scan, checking for infection. Psychosis over delirium, auditory hallucination that are structured and consistent. Personal or family history of psychosis, gradual onset, and history of prodrome. So if it's coming right now and it's only few times and he's having not fluctuant, and it's mainly can give you that this is delirium. Factors favoring delirium over psychosis. where you feel like this patient has visual and tactile hallucination, acute onset, is just started right now of sleep wake changes, global, and then there is medication involvement. Goal is basically to treat the underlying cause, whatever is causing it. So thinking of that one, so always think of the electrolyte, medication, and hydration, dehydration. That's why I said the constipation part. Because of the hydration, the constipation could be there and that can lead toward this one. Ensure regular bowel movement, skin care practices to prevent the pressure ulcers. Then optimize the environment. It's important in checking for the environment, optimize hearing and vision, the checking for the room near nurse's station, then family history, checking orientation, avoid frequent changes, implement the fall prevention, physical restraints, calm and sportive approach for the therapeutic medication. Then go for the treatment. Haloperidol is the one that we give. Then comes the dementia. And the dementia is basically, forgetfulness is there. So Alzheimer, and we already discussed the frontotemporal, Lewy bodies, vascular, normal pressure, hydrocephalus, HIV, prion, Parkinson. So they won't go into very detail of that one, but usually just the diagnosis and the differential diagnosis. And it's very straightforward that this is dementia. If you know dementia, you will be able to reach to that level. So very common is the Alzheimer one, then the other ones. History considered the 7 A's of the dementia, those ones. MMSE, role and dementia scale, frontal assessment, and then MOCA. MOCA was the one I was talking about. Mini-COG is the rapid assessment, 3 minute immediate recall. So checking for that one, Mini-COG. Then always think of syphilis as well. Management is treat the underlying cause, then impaired medications, checking for whatever the medication they're taking and correcting their dose, keep orientation clues, and then in older people, always check for their fall, like prevention from the fall. It's very important. Usually with the psychosis, with dementia, with delirium, they do have a lot of falls. So in the scenario, they can ask you, what would you like to implement this patient, or how would you like to check for this patient, or what would you like to follow up this patient for. So it's basically the fall prevention. And their eyesight is important, vision. Provide education, consider the power of attorney, inform the ministry and transportation if there's a driving problem, then psychological aid is basically you give donepezil and then rivastigmine. Then the antipsychotics, we give the olanzapine. Then you can see the difference from here. Dementia, delirium, if you do just this table, it's more than enough. And then knowing one of the treatment for either for dementia or delirium, don't both implement together. Okay. So do this table and do the treatment. That's about it. And then as I said, we can do the common causes of the dementia. So you can read from the sidebar what are the main sidebar, like just knowing the diagnosis. What is the Alzheimer? Alzheimer is mainly the 80%, 50 to 80% is there. So in this one, there is memory loss. Frontotemporal, the behavior problem. Lewy bodies is basically visual hallucination. Then vascular is basically with the memory problem along with the mood changes, stepwise progression. Then the normal pressure hydrocephalus is basically the urinary incontinence. These are the few lines that I think they will give you in the scenario and can help you to make the diagnosis. Yeah. So when it comes to this drug disorder, so you can always just remember which one are CNS depressants. So if you remember the alcohol, opioids, barbiturates, benzodiazepine, GHB, these are our depressants. So whenever you take the depressants, it decreases the effect. So what can it can cause is basically spleage, confusion, coma. So just remember which one are the depressants, and then it can help you with everything. Okay. And then if you stop those drugs, everything will increase, like anxiety, anhedonia, tremors. You feel like taking it, right? When it comes to stimulants, what are stimulants? Amphetamine, MDMA, cocaine, methylphenidate. So in those ones, what happen? Everything will increase. So when you stop, now you will having craving of those ones. Simple. Then comes the hallucinogens. Which one are those ones? If you take this one, like mescaline, LSD, salvia, PCP, What can get it cause? It causes the increased effect or like the hallucination, psychosis, delirium. And it's usually, if there is no you stop taking it, there's no withdrawal because it's a short term anyway. And then you can ask these questions if you can read this time. Okay. And usually we do the blood screening. That's more cost effective and all that. And then you can always do the urine screening and all of that one based on what it is. How you are going to approach, we already discussed the toxicology. It's just the same. You're starting with don't and then going